the treatment, especially for patients of stable angina. So before we start going into the details, really I would like to thank all our GP colleagues. This evening is dedicated to them, due to which I think during the pandemic as well, if we are able to sit at ease in our home, who takes care of our near and dear ones in such a good way, really we all are thankful to you guys. Thank you so much again. So now this is the framework of the today's evening talk, which we all will be going through. We will try to go through the some of the guidelines. What are the mechanism of action? How do we try to take care of the dosages? And finally, we'll try to summarize it up as well. So we all are aware any kind of medication if we are using, so we try to aim, and of course there are also guidelines as well, which try to help us how we can use an agent. So for example, especially for the patients of angina, we all have to try to take care that their quality of life tends to improve, they do not get any of those symptoms, and of course in the meantime, if we can try to prevent any complications in the form of a heart attack as well. So we all are aware that according to the guidelines, we have to give preference to the agents like the beta blockers or the calcium channel blockers. However, on the ground realities, which we all will agree that it's not always so easy to manage those patients. So other than beta blockers or calcium channel blockers, we have to depend upon some of the other medications as well, for which there are various options, including the nitrates, nicorandil, ivabradine, or medications like ranolazine, in fact. So we all have to understand that what is the real mechanism. It will also give us in uh, about its usage for other medical conditions. So, for example, we all understand the even in the at the level of the heart, it's all about supply and demand. So, if the heart is in stress, there's increased oxygen demand, and of course, when there is lower oxygen supply, that's where the imbalance happens, which can initially lead to ischemia, and in later on can further complicate in terms of infarction as well. And if we are not able to further control it, these are the cycles which will even lead to diastolic heart failure. So, if we will all recall our physiology days, so for the contraction, sodium channels will be there, through which, if the late sodium entrance channels will be getting affected, so which is the mechanism of action also for molecules like ranolazine, we will be able to notice that we will be able to impact its entry into the cell, and in fact also prevent something what is called as a sodium overload, which in turn tends to cause the calcium overload. And as we all are aware, hypercalcemia is one of the states in which can lead to diastolic heart failure as well. So, for example, if we are able to prevent calcium overload, we will be able to also take care of the diastolic relaxation failure or the coronary compression. So there are various parameters on which ranolazine is able to act. Now, on the cellular level, as we already understood, the imbalance between the sodium channels and finally, which leads up to the calcium overload, in fact. So, if we take care of both of them, we can not only decrease the myocardial oxygen consumption, in fact, also favorably alter the myocardial blood flow and the oxygen supply as well. So, on an overall basis, we will be able to not only control the symptoms but also the associated complications as well. So, if we look carefully into this animation, as we can notice during ischemia, where there will be an enhanced late entrance of the sodium channels, if we try to take care of that, we will be able to prevent the calcium overload. Uh, okay, and we will be able to prevent the clinical episodes. due to which, if we can see it over here, those patients with symptomatic chest pain will have a lesser episode of chest pain, and also the diastolic relaxation and the myocardial blood flow is going to be further improved. We all believe in evidence-based medicine. It's not like this that a professor, some famous professor said it like this, that okay, this is what it should be done, this should be done. No. So what happens is, even when they try to see just on 3 months of a study, when they try to see how about the anginal symptoms when this medication is being used, then they were able to notice, in fact, there was a significant 42% reduction in those weekly chest pain episodes, which we classically describe it as an angina. And even European Society of Cardiology has a very stepwise, detailed approach whenever we come across these kind of patients. Yes, we all have to personalize the therapy in terms of the comorbidities, what they are having, what about the baseline characteristics, what about the different comorbidities as well. So on a normal basis, as I had already shared, we try to initiate them on beta blocker or calcium channel blocker, and maybe if possible try to combine them, and if they still continue to be symptomatic, try to add a second line drug as well. So a lot of times we come across those patients whose heart rate will be slightly on the higher side. Yes, this combination will be really great. We can even try to add a ivabradine as well. However, the confusion comes when there is a patient with a low blood pressure. Otherwise, when there is a heart rate is on the slightly on the lower side, then it situation becomes tricky. We have to start thinking like, what about the other agents? So that is where the role of other agents comes, like ranolazine, nicorandil, trimetazidine as well. So there's a interesting Manolus review in which they have tried to put up together the all anti-anginal treatments as well, and especially in terms of the mortality. And as I had said it, it's most of the times, most of our patients as well, they need, or I would say rather, they deserve a second a line of therapy as well, because most of the times if we are trying to take care, they may not be having such a good symptomatic relief. And as I had said, it is heart rate is an important factor. So as we can see beautifully in this chart as well, if someone's heart rate is more than 60 beats per minute, then again we always look at the blood pressure. If it is on the significantly lower side, then we have to, of course, consider ranolazine or ivabradine. However, if it is again on the higher side, then we can try to consider a non-dihydropyridine calcium channel blocker. And even with that, if we are not able to further control, we can consider adding some of the other medications. And same thing happens even if the heart rate is lower, because we all understand the beta blockers or the calcium channel blockers as well can itself bring down the heart rate. And we all will, I think, agree, and we all have seen that we all tend to call like diabetic patients as the coronary artery disease equivalents. So we all get concerned, like, okay, if I am trying to start someone on this medication, how is it going to affect the, the glucose level, or how about the glycosylated hemoglobin levels as well? Is it going to affect that? So I will try to focus on the next coming few slides on that topic as well. So this was an important slide. This is an important slide in which when they try to compare for the patients who are having those chest pains, so we were able to notice with the passage of time, at the follow of nearly 3 months, there was a significant uh, improvement in the quality of life, or the delimitation, especially with the chest pain, was much lesser when a medication like this was being used. And not just that, one of the things what we all are worried is, about the possible side effects of any of these medications what we all are using. So I must say that it happens is anyone, if we are suspecting for the chest pain and all, we tend to blindly literally ask them to, okay, use a GTN spray. Nitrates will be really good for you. But nitrates, these themselves can have their own side effects as well. The episodes of hypertension, or they are not the treatment. In fact, we all should keep it in mind. So what happens is, even at the end of 3 months, with the usage of ranolazine, we have been able to notice that there was lesser usage of the nitrates. In fact, as I had already said it, uh, we all will further agree that most of our angina patients tend to be elderly people. So in the elderly people as well, it we were able to notice there was a physical enhancement. So, for example, the quality of life improved. They were able to do more things as well. So, as we can see, so this is the CCS for the Canadian classification of for them. So, in this, as we can already notice, even if someone was in class 1 or class 2 or class 3 or even class 4 as well, there was a significant improvement, especially for those patients who were started on this. So uh, we all have to take care that not just we are trying to aim for the functional improvement, but also we are trying to see for the quality of care, life as well. QOL, what we call it as, not just in cardiology, but in most of the specialty. That's what we all are really bothered. So even on parameters of QL as well, there was a nearly 44% improvement, which was noticed by the physicians. So, especially in my syncope clinics and all, a lot of times whenever I come across cardiology patients, we all come across that they will be on beta blockers or calcium channel blockers, and as I said it just a few seconds back as well, nitrates. And what will happen is they will be the ones who will be also coming to us or even to the A&E, which is, really say it like, red flags with syncope. And what will happen is they will be telling, oh, I was trying to get up from the chair and, all of a sudden I felt lightheaded. So it not just increases or consumes our GP's valuable time as well, it also may, especially during the COVID-19 times when we are trying to talk about optimal usage of the resources, it may uh, cause unnecessary trouble to all the other healthcare professionals as well due to the associated side effects like the bradycardia, the hypertension, or the vasovagal collapse as well, which is associated with the beta blockers or the calcium channel blockers as well. So, further, as I was already telling that we all have to be careful for our elderly people because they not only need more care, they also deserve more attention due to the comorbidities which they all are having, and in fact about the symptoms as well. Uh, so when they try to compare for such kind of sub set of population, they were able to notice that especially in the elderly population, there was good improvement in the exercise duration. So it also led into the quality of life improvement for such kind of patients, which was also recognized by the European Society of Cardiology as well. So the group sub meta-analysis is very important. As I was already telling, is for both the groups there had been good amount of improvement. They also try to compare that how about the improvement if tried with a beta blocker, a calcium channel blocker as well. But we all are aware that there are unwanted side effects which can be associated with the other drugs. So one of the significant comorbidity which we all have to deal with is diabetes, diabetic patients, because being a diabetic patient itself, they tend to have a higher risk of developing a coronary artery disease. In fact, the blood vessels as well, they tend to be more complicated, and in fact, even after the revascularization has been done, they will again have a higher risk for development of coronary artery disease or even restenosis as well. So, ranolazine is able to even improve the glycemic control by decreasing the glucagon levels. So, if we will try to look carefully on this wonderful slide, we are able to notice that uh, not just in diabetic patients, but also in non diabetic patients as well, we are able to notice that in glycosylated hemoglobin, there was an improvement. And if you will look carefully, I will show you the p value as well. I think, we all will be pretty amazed. So, a simple question comes: why is it so? What is the reason that there is, the hypoglycemia episodes also are not there? So, because what can one think is like, oh, 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 what happened to my slides? Yeah. So we all will start to think that what is the reason? Maybe it is causing hypoglycemia episodes. That is how we are able to achieve better glycosylated hemoglobin levels. No. But again, if we will try to look carefully into its mechanism of action, it is a multi pronged strategy. Multi pronged strategy, what I'm telling is the sodium channels, which is there in the pancreatic alpha cells, they also get blocked. And in fact, if you may recall from the calcium levels, so it tends to prevent the rise in the cytosolic calcium levels. And even what happens on an ultimate basis, it will reduce the glucagon release. Therefore, there will be a reduction in the hyperglycemia, which is most of the common cause for affecting the glycosylated hemoglobin. And we all will agree that if we are able to control the glycosylated hemoglobin levels, the morbidity or even the mortality of the disease will improve. And one of the big challenges, I think all my colleagues over here will agree that we all have to deal with what is called as a microvascular angina. This is a very special thing, I would say, and a bit challenging as well in the sense uh, what happens is uh, nowadays cardiology is evolving even more. It is not just on the level of anatomical basis, but also on the molecular basis as well. So what is happening is we are able to notice evidences of myocardial ischemia, especially on a lot of non-invasive testing. So what will happen is, oh, the patient has come with a chest pain, we get a angiogram done, CT coronary angiogram done, it is normal. So what will happen is sometimes they will be again coming, we get a troponin levels, okay, it might be a little bit higher and all. So it becomes like a problem. And what happens is, uh, especially those patients, this phenomenon tends to be more common in females, especially those postmenopausal age. And then we try to think like, how can we try to make it better? So how to make or improve their mortality as well. So what happens is they try to do study, they try to in fact look carefully for such kind of patients. So on molecular basis, what was seen was there were two mechanisms which was responsible for it. One is the impaired vasodilatation, which is secondary to the endothelin. So that is where the role of endothelium derived relaxing factor, EDRF, comes. And also there's increased vasoconstriction secondary to endothelin 1 or catecholamines as well, or acetylcholines. So, microvascular dysfunction has a very important role to play, especially for such microvascular angina patients. So, depending upon those mechanisms, if we are trying to take care of our patients, if we are trying to help our patients, if we can take care of those two factors, definitely we will be able to help those patients, and so much so that the coronary blood flow to the sites of the coronary microvasculature will not get affected, and in fact, those myocardial perfusion defects or even the subsequent development of the LV dysfunction will not be happening at all for such kind of patients. So, when they try to see for the quality of life scores, the Euro QIL or SEQ scores as well, when these patients were treated on ivabradine versus ranolazine as well, this is a very interesting curve which we all are able to see over here. So, as I was telling that, yes, it tends to happen most commonly in females, but when we try to look carefully over here, if we will look the darker one, it tends to refer to ranolazine, and the grayish one is the one which refers to ivabradine as well. So, on an overall basis, in terms of physical limitation or treatment satisfaction, disease perception, and the quality of life improvement score as well, and also on terms of angina frequency, the improvement in the group which was on ranolazine was significantly higher. So, one of the common questions which we all come across in our day to day life is how about the indication and dosage? So, we all have to keep it in mind that we have to take a stepwise approach. So, we initially try to initiate on 375 milligrams BD, wait for 2 to 4 weeks, and it can be up titrated to 500 milligrams BD. Again, after 2 to 4 weeks, depending upon the response, we can further up titrate it to 750 milligrams BD. However, it does happen. Some of them may not be able to tolerate the dosage, otherwise, there may be some adverse event as well. So, for adverse event, I really say it like this, rather than immediately stopping the medication, let's try go back or go down titrate the dose, and we can try to notice how is the effect of the down titration. Quite a lot of it, I would say that we will be able to notice that those patients start doing much better. And yes, I try to always ask them two things. Is it bothersome? How is the side effect? Okay, if you are having this, are you having such kind of problem like a headache? Someone will be telling like I'm experiencing dizziness or constipation. I ask them really like, is it bothersome to you, or do you think shall we try to see for a few more days? And what happens is, yes, those side effects will be happening in at the most in like initial first week, or at the most is 1 to 2 week, and after that, what we all have come across is they tend to start doing better. So the up titration of the dosage is not something big, and I'm sure our GP colleagues will be really comfortable to be able to take care of this thing as well. And we, in the meantime, yes, there's some of the contraindications which we all have to be careful is the renal impairment. So if someone is having a severe renal impairment, we all have to be really careful. Otherwise, also with patients with moderate or severe hepatic impairment as well. And about antiarrhythmic drug. I mean, if someone is on amiodarone, fine, but not with class 1A, especially the class 3. Why I'm telling is class 1A, because if you may all recall, you all are now the masters. Because of its effect on the sodium channel, class 1A antiarrhythmic drugs is the sodium channel blocker. So, so now coming towards the end, to be able to summarize, we all will agree now that it is not just well tolerated, in fact, and the side effects for this medication are not much bothersome, and in fact, it does not. This medication especially does not depend upon the heart rate, blood pressure, or also the vasodilation to be able to deliver the additional anti-anginal effect. And yes, it is also tends to have a very favorable effect on the diastolic relaxation and also the myocardial blood flow. So therefore, even there are significant evidences which has shown that it tends to reduce the angina episodes, and not just in cardiac patients, but also especially in those patients who are having the type 2 diabetes mellitus, or even someone with having a history of microvascular angina as well. So this is the prescribing information in very much detail, for which we have already touched. Thank you so much for your patience, and I'll be more than happy to answer if there are any questions.